Well, good afternoon. My name is Jennifer Boyne, and I'm on the board of directors for Soft Bones Canada. Thank you for joining us today for this webinar. The focus of this presentation will be on hypophosphatasia as it pertains to teeth. As you know, hypophosphatasia is primarily thought of as a rare metabolic bone disorder, but it is also a tooth disorder that disrupts mineralization. We're thankful to have expert presenters with us today to share their knowledge about teeth and HPP. Dr. Mark McKee and Dr. Robert Schroth both sit on the Scientific Advisory Board of Soft Bones Canada, and we're pleased to have them with us today. I will be introducing each doctor and having them present their slides to you. During the presentation, please feel free to ask questions. We certainly hope that you will. There's a Q&A button at the bottom of your screen or possibly on this side. So feel free to type your question in that area, and we'll do our best at the end to get to those questions. Please keep in mind we are going to be recording this, so anybody who missed it or can't stay for the whole presentation, we will make sure that it's available on the Soft Bones website as well. And at the end, we'll stop recording so that we can have a little bit more of a more intimate conversation back and forth with the doctors with any questions that you might have. So if Dr. McKee is ready, I'm going to get started with a little introduction about him to give you some background. Dr. Mark McKee is a professor at McGill University in Montreal, where he holds the Canada Research Chair in Biomineralization with a joint appointment in dentistry and medicine. He received his PhD from McGill University, followed by postdoctoral training at Harvard, the Children's Hospital Boston, and then held appointments at the Forsyth Institute in Boston and the University of Montreal. His research focuses on biomineralization in bones and teeth, otoconia and eggshells, and in pathologic calcification. With over 225 publications and 25,000 citations, and for his accomplishment in mineralization research, he has received 2 Distinguished Scientist Awards from the International Association for Dental Research and the Adele Bosky Esteemed Award from the American Society for Bone and Mineral Research. He also received the C.P. LeBlond Award, honoring a Quebec scientist for exceptional involvement in bone and tooth research. So welcome, Dr. McKee.
Thank you so much, Jen. Thanks for that generous time with the introduction. So welcome to everybody, to all the participants. It's very nice that you're here. I will be discussing a few of the things that I mentioned back in 2016 when I spoke of this topic at the first National Hypophosphatasia meeting for Canada out in Winnipeg. And that's where I met Dr. Schroth, my co-presenter here today. And it's very nice to be back, and it's nice to contribute to the Soft Bones Canada website webinar series, and I'm happy to do so. So welcome to all of you, and I think get started, share screen, host disabled participant screen sharing. I'm getting a message, Eric and Jen, I cannot screen share. Can you enable me, please? For those of you who can hear, I'm still waiting. Okay, here we go. This will stop. Thank you, Eric. Thank you, Jen. Okay, I presume that we're good now. All right. Let me just get my arrow going. Okay, so please note my disclosures here at the bottom. Take a minute for you to read them. Okay, so my task today and my pleasure today is to say a few things in about 20 minutes or so from now, so that those of you listening can understand some very basic principles about tooth formation and eruption and mineralization. I mean, that's what we're talking about today. I'll discuss a little bit what is bone and tooth mineral, where is it exactly in the tooth, and we have lots of information on bone too, but we're going to focus on teeth today. and what's wrong with mineralization, the mineral in HPP patients. And I'll also discuss how and where does HPP specifically affect in the teeth, which structures. And just a slide or two, most of you are familiar with everything that's happened, but how is Strensiq then expected to work for tooth health, aspartate alpha. Okay, so let's do a few things about the biology of tooth development for those of you who don't know, and I'll try and keep it simple as I can. So in utero, after conception, right, many of the main organisms, many of the main organs in an organism like we are, have actually been established by about 2 months after conception. So that kind of puts a time frame, and you see a picture here of about a 2-month humanoid embryo. And so major organs are forming, a lot of things are going on, and the tooth formation starts a little bit later than the other organ systems, but very close to it. So tooth formation starts at about 2 months of age in utero, in the embryo. So at the end of the day, this is what we're going to have with teeth. So in a child, our first set of teeth, the primary teeth, the baby teeth, the milk teeth, the child will have about 20 of those teeth, and you know, plus or minus things happen, but we all had more or less 20 teeth when we were younger, and your kids will have 20 teeth when they're a child. And the teeth, you know, consist of a crown. There's an anatomical crown and a clinical crown, what you can actually see above the gums, and a root. And particular importance to hypophosphatasia is the root structure. So I'll be spending extra time with that. The teeth, of course, do not exist alone, right? They're surrounded by tissues called the periodontium. And specifically, we'll be talking about the ligament and the bone. So teeth are not fused to bone. There's actually a very tight, intricate ligament called the periodontal around the tooth ligament that's very important for HPP community to know about. So primary tooth movement and eruption, so I already talked about formation at about 2 months, starts to occur about 4 to 6 months after birth. So we have a lot of things to do in utero, in the embryo. And the way it works is a tooth forms first with its crown. So the crown is formed first, and only later does that root extend below the crown, and that actually participates in the eruption process. With time, right, we go from a few teeth in the children, we go to a full set of 20 teeth, 5 in each quadrant. And the primary baby teeth start to resorb and crowns fall out. Not so obvious in hypophosphatasia, but in normal people, the crowns will fall out after there's some degree of root resorption. And so that takes place with permanent teeth starting to erupt at about 5 to 6 years of age. Okay, so before that, we're talking about the baby teeth, and after 5 to 6 years of age, the baby teeth start falling out and the permanent teeth start coming in. And we have more permanent teeth than we do baby teeth. We have 32 permanent teeth compared to 20 in teeth. And why is that? Well, the head grows larger. We can only accommodate, in a young child, we can only accommodate 20 teeth or so. And then we have one chance, a renewal of those 20 teeth and adding some additional teeth to form an adult dentition as the head gets bigger and can accommodate the teeth. And very important in that process is a tooth resorption process. So here's the baby tooth up here, surrounded by this pink bone, and here's a permanent tooth that will replace this baby tooth. So you have to get this baby tooth out of the way. You have to resorb its roots, which do not occur so well in hypophosphatasia, in order to make a path trajectory for this permanent tooth to erupt into the oral cavity. And so that's a big picture about teeth, from 20 in kids to 32 in adults, replacing some teeth. And to get from 20 to 32, you have to add a few more teeth in each quadrant. And that's what happens. Oh yeah, and this is a bit grotesque, I realize, but I've tried to say that at the end of the day, we're not in a baby, but we do have to get our 32 teeth packed into an adult head. Okay, now this may look complicated, but I just want you to focus on the circles. I think it's good if we all know a little bit about how our teeth start when we were in utero. And you can see here by the circles, if you were to take a section through a head of an embryo in a coronal fashion this way, parallel to the face, you would get an image like this, and you can see that in a microscope. You would have a tongue here. Here would be the lower part of the face where the mandible would be forming, the upper part where the maxilla jawbone and the palate would be forming. And just in this plane of section, in these yellow circles, you can see these structures, these cap-like structures here, little tooks, Canadian tooks for a cold winter. And these are where early sites of cells are starting to proliferate and grow. And this is the future site of a tooth. And all around this will form bone, and you'll get the jawbone. But these four, and there's other sites too in different planes of section, these four circles show tooth germs, tooth buds that are just starting. And with time in utero, the tooth buds, the cells in your face, will start producing tooth substance, enamel and dentin, and then later roots. And now you don't really see the cells so much. Now what you're actually seeing is the actual tissues of the crown. There's some enamel there, and there's some dentin. So here's a tooth crown, no root, in the maxilla, and here's a tooth crown being formed inside this pink bone in the mandibular jawbone, and there's a tongue for reference. So this is how it all starts. Cells grow into, and this is the last kind of technical microscopy slide. But if this is your oral cavity, okay, your tongue would be above this. If this is your oral cavity space right inside your mouth, when we were all embryos, the cells at the lining neural cavity, they start to invaginate and grow deep down into the tissue. And this will be the furrow behind your lip. And this growth down forms this cap. And this is the future site where a tooth will form right in here. These are the cells that make the tooth. This is what it looks like in 3 dimensions, lots of blood vessels and whatnot coming in. And these are the cells that will make the crown of your tooth, begin the process, the induction process. And the bone, at the same time, is being inducted by bone cells, are making bone that will form the future jaw around the teeth, and the tooth cells will make the future tooth. So that's what it looks like in a growing embryo, even before you get to actual tooth substance. And I thought that's interesting, and I thought you should know that. So finally then, in the early years in a child, to get to those 20 baby teeth, milk teeth, primary teeth, finally at the end, 5 in each quadrant, you go through a series of tooth development and tooth eruption, right? The teeth form inside the tissues in the jawbone, but when they're ready, they start forming a root and they start erupting into the oral cavity. And each tooth has a different timetable for eruption, and it varies from person to person. These are not exact. That's why I just drew a rough range arrow here. Every child does it slightly differently. And then you get your full dentition. And the permanent teeth then will start erupting and will replace this child's dentition at about 5 to 6 years old. The permanent teeth start erupting to replace those. So normally you would have some erosion, some resorption of these baby teeth to get to the permanent teeth. And in these models, you can just see all these events that are occurring all at once. So when you're a child, you have your baby teeth here, but at the same time, you have to get started, right? You have to start growing the crowns of your permanent teeth in both the jaw bones, and that continues in the adolescence, the crowns are more developed, and here in the adolescent, the roots are just starting to form. So the child still has their baby teeth, but we're really getting down to business deeper in the tissue to make the permanent dentition. And finally, you will lose all the baby teeth and you will end up with your 8 in each quadrant, 32 adult teeth. And you know, that is the goal of biology, to get those teeth in the right place and the right number and so on and so forth. And if you look at the real thing, a dissected anatomy specimen here from the McGill Medical School maybe, or from a textbook, I forget, you can actually see they've cut away the jawbone here of the mandible. You can see some of the permanent tooth crowns forming in the bone that will eventually resorb the roots, and this primary dentition will ultimately be lost. Resorb roots look like this. A full resorption leaves just a piece of the crown, and that's what normally falls out in a healthy child's mouth. And then you get to the adult dentition when there's no more tooth development going on. It's a done deal, and that's why you have to take really good care of your teeth, because there's only one renewal from the baby teeth to the adult teeth, and that's it. There are researchers working on tooth regeneration strategies, but we're not quite there yet. Okay, so building a tooth. So how does the body know where to build a tooth? You have your gums. If you have your newborn infant and you pull up the lips and you look at the gums and you don't see any teeth, right? But during embryogenesis, of course, teeth are been forming right down inside the gums and inside the jawbone of that young infant. And so how does biology decide where we're going to put a tooth? Here, 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 and get exactly, 5 per quadrant, and get 10 teeth in the upper jaw, 10 teeth in the lower jaw. Well, apparently there's a ridge of tissue right around in each jaw site. There's a ridge of tissue that's very active in producing signaling molecules, and this is molecular biology. And that ridge, if you open up the mouth like this, and you look at that ridge on the top, and you look at that ridge on the bottom, there's a band of tissue here that's very active and very potent, and is able to induce and talk to the cells underneath it to induce these tooth germs. And these are what you want to get started. I showed you those microscope images. You want to get started with these tooth germs, 10 of them in the upper jaw, 10 in the lower jaw, and you want to get those tooth germs, yes, here they come. You want to get 10 of them. I only drew 4 here so that you could see them better. But at the right place with a bunch of molecular signaling taking place right here, you can get these 10 tooth germs in the right place, and you can induce tooth formation inside the jaws. And that's exactly what happens. And there's a signaling event that starts tooth formation in utero, and away you go. So that's how it all starts. So let's take the last half of my session and talk about a few of the things, of the learning objectives, and we'll start with the structure of the periodontium, meaning the tissues around the teeth. So please understand that a tooth itself is actually consisting of 3 different tissues, right? 3 mineralized tissues. The enamel of the crown is a mineralized tissue with calcium and phosphate in it, just like the dentin, but they all have very different structures and very different functions. The dentin forms first, actually, the crown dentin, and supports and provides a scaffold for the enamel. They form very close in the timetable, but one after another. And you start building your crown, and the dentin is there. And there's a third tissue that people know less about, coating the surface of the root, and it's called cementum. So we have 3 tissues constituting a tooth per se: cementum, dentin, and enamel at the surface. So you will notice that there's something called crown dentin, and there's also something called root dentin. But the cementum is only present on the root. And I'll tell you more about what cementum is. The teeth are suspended, not fused, not attached to the bone. The teeth are suspended by a ligament, and that's drawn in here in yellow, a ligament of collagen that suspends it like a hammock inside the bone of the jaws. So there's a sling, hammock sling in yellow here of periodontal ligament that's suspending our teeth. And then there's the pulp, of course, in the middle. And let's march through a few of those structures. So I already told you that for at least the crowns of the teeth, we have something called that tooth germ that started the whole process. I told you that after it induces the crown of a tooth, and here are the cells, we start to actually make tooth substance, enamel and dentin. The enamel layer inside an embryo is this black layer. This pink layer is the dentin. The pulp is in the middle. The cells are surrounding the tooth on the outside, surrounding the future pulp. The cells are here that make the dentin on the inside. And so you're really going now full steam ahead. You've started to build a tooth, at least the crown of the tooth. But what's particularly important for hypophosphatasia patients and our understanding of hypophosphatasia is the root elongation process and the root structure itself. And so to form root dentin and root cementum, these are the names that are given to them: dentinogenesis, birth of dentin, birth of cementum. And we will develop these roots, and the roots participate in the final shape of the tooth. They participate in how well the tooth is suspended inside the jaw bones, and very important to mastication and chewing. And teeth have different numbers of roots. Some have one root, some have two, some have three, sometimes even four. And this is quite variable between people. It follows a main theme, but sometimes people have a few less teeth, a few more roots, a few less roots. There is some variation in that. So once you form the crown, you then need to form, very importantly, a root. And so from that tooth germ, certain cells at the tip, and here in higher magnification, will start growing down into your jaw bones, or if it's your maxilla, growing up, let's say, into your maxilla. And you start to induce cells to come down, which in turn will induce root structure. So down you come and you start elongating this tooth. And as you elongate, you're starting from a crown, and as you elongate in the jaw bones, the root gets longer and longer. You also, at the same time, of course, have to develop the surrounding bone of the jaw. The jaw is growing too, the brain is growing, the teeth are growing. And you have at the same time construct the ligament, the periodontal ligament, that will suspend like a hammock sling these developing roots inside the jawbone, which is here. So the tooth is forming, the bone is forming, the periodontal ligament is forming, and that all has to be beautifully coordinated so that we can attach the teeth via a ligament to the surrounding alveolar bone. And that's exactly what happens. And yeah, these are just higher magnifications of the various tissues. But the important point here is that you have to link the ligament, attach the ligament on one side, the root side of the tooth, and you have to attach the ligament to the bone on the outside of the tooth, so the jawbone side. And these attachment points are defective in hypophosphatasia, and I'll tell you why. Okay, so we need to attach. The way we attach them is we build some cementum on the side like a glue, and we mineralize it. We harden it with calcium and phosphate in a normal tooth. The same thing happens on the bone side. The ends of the ligaments are incorporated into the bone, mineralized to harden and glue them to the jaw bones. So with your two anchors, anchored by mineralization at each end, which is defective in hypophosphatasia, you get a nice firm tooth attachment. If you don't have those nice attachments, you have either a loose tooth or a lost tooth, and we'll come to that. This is just a beautiful picture of a tooth, two molars cut this way in cross section, just to illustrate the extent of this periodontal ligament to keep teeth in the jaws. If you look down at this teeth, so this is one molar with three roots cut in cross section. Here's a second molar with three roots cut in cross section. And if you look closely at the very surface of the root, this thin dark layer is the cementum, the attachment point of the ligament. There's ligament going across, and it inserts to the attachment point on the surrounding jawbone. Yeah, jawbone is kind of porous and loose looking compared to the teeth. But that's how it looks, and you can see ligament all the way around each and every one of these roots. And that's why it's normally so hard to pull out a tooth. And yeah, Here you can see the details one more time in a real microscope section. This is tooth dentin. There's that layer of cementum that hypophosphatasia patients do not have. There's the ligament spanning the space between the tooth and the bone, and that ligament is supposed to insert and be hardened at those locations. And here's some more detail, I guess, more detail than you need to know, but these two sites where the ligament attaches on the bone is called attachment zone, and there's an attachment bone on the cementum tooth side. And in hypophosphatasia, big problem here, where I put an X, is that although there may be some structure there, there's a defect in the mineralization, as many of you know, and you do not get a good attachment. On the cementum side, the cementum is actually missing or very little. The problem on the bone side is the bone is not well mineralized and cannot anchor well the bone side of the ligament. And so in the last couple slides here now, I'm coming to an end. This is the story that at least the patients know well about, that the problem in hypophosphatasia is about this small inhibitory molecule called pyrophosphate, or PPI. The PPI accumulates in the patients, in the bones and in the teeth, in the cementum area, in the dentin area, and that PPI binds and blocks mineral crystals, calcium phosphate crystals. It inhibits them from growing because PPI attaches very strongly to mineral, but in so doing, it blocks the future growth of that mineral. So it decreases mineralization in the patients because they have too much PPI flooding their bone and tooth tissues. In a normal person without TNAP mutations, inactivating TNAP mutations, the cells of bones and teeth, here's the cells, osteoblasts and cementoblasts, will degrade and cleave and break away the phosphate inhibitor, thus allowing calcium and phosphate to deposit, allowing mineralization to go, green light go in the bones and the teeth, because they're making the enzyme to remove this important inhibitory block on tooth mineralization and on bone mineralization. So with many, many different mutations on TNAP affecting the gene, either strongly or mildly, the patients have tons of pyrophosphate building up in their bones. This blue is soft bone. Here it's mineralized a little bit, but all this should be black with mineral, and it's not. The pyrophosphate accumulates in the bones, in the hands, everywhere in the skeleton, in the teeth. So we have osteomalacia and odontomalacia. And so there's a softness everywhere because there's accumulated pyrophosphate in the absence of this enzyme, or a weakened enzyme, depends on the mutation you have. So in summary, then you have normal people have good production of abundant enzyme TNAP to remove the inhibitory PPI, but HPP patients in the tooth have the buildup blocking the attachment on the tooth side, not having a good attachment on the bone side because of poor mineralization, and that causes instability of that tooth. And so many of you on this call may have experienced this, of course, but instead of losing just crowns of teeth, you are losing whole rooted tooth atraumatically that are sliding out of the socket. Why are they sliding out of the socket? Because they don't have a good attachment. They don't have good mineralization because of all that pyrophosphate building up because of their TNAP mutations. And so the last slide here, most of you are familiar then with the strategy for aspartase alpha or Strensic then, is to deliver the enzyme, good, healthy enzyme without mutation, protein mutations in it so that it works properly. Use a kind of a protein fusion peptide that will bind very well to the existing mineral. If there was no existing mineral in an infant, this therapy might not work. It targets to the mineral in the bones and the teeth and allows pyrophosphate to be removed. And that's the enzyme replacement therapy. Try and get it to the little bit of mineral that exists in the patients. Try and get it in that soft blue bone to render it very black and hard and mineralized like it's supposed to be. And the same thing would happen in the tooth attachment apparatus. So that's kind of the story, from some basic biology to some basics about tooth structure and eruption and mineral, and how an enzyme can remove inhibitors that patients have trouble removing. I've been involved in this work for many years, so nothing specific to this presentation, but over the years I've worked with many wonderful people, and you'll recognize even some of the children maybe in this slide. So thank you very much for your attention, and I think we're taking questions at the end after we hear from Dr. Schroth. Thank you.
Okay, thanks so much, Dr. McKee. We really appreciate that. I was noticing in those pictures that those pictures of the teeth look like the ones my mom saved, and we would look back at and think how interesting and very bizarre my teeth were compared to some of the other kids, including my brothers. So anyway, thank you for that. And we will get to some questions at the end. I may have some questions myself, so thank you for that. I want to introduce Dr. Robert Schroth. He is a professor in the departments of Preventative Dental Science and the departments of Pediatrics and Child Health and Community Health Sciences in the Rady Faculty of Health Sciences at the University of Manitoba. He's also a research scientist at the Children's Hospital Research Institute of Manitoba. Dr. Schroth is a dental clinician scientist practicing out of 2 inner-city community-based dental clinics in Winnipeg. His research focuses on early childhood oral health and the epidemiology of early childhood caries, ECC, in at-risk populations, particularly among Indigenous children. Some of his work has examined the role of prenatal factors, including vitamin D levels, on the oral health of infants and preschool children. His research has also documented associations between ECC and poor nutritional status. He co-leads an early childhood oral health promotion and ECC prevention project in Manitoba called Healthy Smile, Healthy Child, which uses community development principles to promote oral health and includes program evaluation and research. And as I mentioned, we're fortunate that Dr. Schroth is with us on our scientific advisory board. And I'd just like to point out that he's also done some studies with those who have been able to take Strensiq, and hopefully he'll be able to add some wisdom at that end today. So thank you for joining us.
Perfect. Thanks so much for the kind words of introduction, and it's great to follow Dr. McKee for laying the groundwork. So I will just get my slideshow all set up, and we will go from the beginning. So just some disclosures that I do need to make. I do co-chair the Canada-US chapter of the Alliance for a Cavity-Free Future. I wear some leadership hats within the Winnipeg Regional Health Authority within the Oral Health Program. And currently I chair the Canadian Dental Association's Committee on Clinical and Scientific Affairs. So as Dr. McKee has already mentioned, dental issues amongst patients with HPP are I think our biggest identified sort of feature is the premature loss of primary teeth. And this can even happen before 18 months of age in some individuals. And that's because of the missing cementum or malformed cementum and the attachment of that periodontal ligament. The other factors that we also sometimes see within teeth of HPP affected individuals is enlarged dental pulp areas. And why is this a concern? I think for me as a clinician, when caring for individuals, when you have these larger pulp spaces where the nerve and blood vessels are, that often means that the other aspects of the tooth, that enamel and dentin, are quite thin. And as the cavity process, if an individual does get tooth decay, it can progress rapidly. And so a small cavity could actually have dire consequences if you have a large pulp chamber and the cavity travels towards the pulp, leading to pain. It's not just the enamel that's affected. Sometimes in individuals with HPP, there can be irregular formation of the dentin tissues as well, and that also might be delayed. As well, something that's often seen in individuals with HPP, their enamel often looks like there's maybe pitting or missing areas of enamel. And these enamel defects are a concern for the practicing clinician because it's an area where enamel's either missing or very thin. which means the cavity process could progress rapidly. These irregular areas are also easily sort of colonized by cavity-causing bacteria, which can then, they're a little bit tougher to clean as well, which means the cavity process can progress rapidly as well. And depending on where they are in the mouth, some of these defects might actually be unattractive to patients and families. Fortunately, there are some ways that we can, with dental materials, cover over some of these areas just to mask them. In the adult teeth, there are instances where some individuals will have premature loss of permanent teeth or as well possible delayed eruption of permanent teeth. Amongst the different forms of HPP, some have classified some of the significant dental features. So in the infantile and the childhood forms of HPP, the premature loss of primary teeth is very frequent and common. However, in individuals maybe diagnosed with adult HPP, they may tell you that they have a history of premature loss of primary teeth, and they may actually show loss of some adult teeth and an abnormal dentition. So things are not quite what we typically see in patients without HPP. And then in those individuals with just the odonto hypophosphatasia form, we know that they show signs of early loss of these baby teeth. There may be reduced thickness of the dentin. These dental sort of nerve areas are a little bit larger, and they may be prone to more dental tooth decay. So here's a little bit of a look at some x-rays and sort of why maybe the frequency of dental radiographs is important for individuals with HPP, or a parent if your child has HPP. It might be something that's important for regular follow-up, especially maybe when you can't see all surfaces of the teeth. So here the arrow is pointing to a permanent molar where you see sort of an enlarged sort of black area in the middle of the crown of the tooth, and that space is a little bit larger than what we would typically see. In some areas, there may be some affected bone height, so the amount of bone around some teeth may be affected, and as well, mobility in anterior teeth is often seen. So we recommend sort of radiographs or x-rays should maybe be considered a little bit maybe more frequently for children with HPP, and maybe as well adults with HPP. More frequent x-rays might be beneficial just to make sure that bone levels and tooth structure and are sort of always sort of assessed to make sure that no problems arise. Here are some radiographs. This is an adult patient with HPP. And as you can see, something looks a little bit different. I sort of liken sort of these premolar teeth to sort of almost like muffin tops, where they're sort of a little bit more bulbous, and there almost appears to be sort of notching in spaces where maybe the enamel and the cementum on the root would normally form together. So things just look like the enamel isn't formed properly, which, you know, if it's very, very irregular, tough to clean, and might increase an individual's risk for tooth decay. The other thing that we notice on the x-rays is that in some of the premolars specifically, we do see sort of larger pulp chambers, sort of that pulp area where the nerves and the blood vessels are within the crown of the teeth. So a little bit sort of wider than we may typically see. I often get asked questions about sort of, you know, how important is dental care? And I think like any other child, we do want to make sure that young children with HPP are also picked up and connected with a dental office at a very early age. So we know that that first visit before that first birthday is really critical. And especially maybe if you have a family history of HPP, or you know your child is diagnosed very early with HPP, connecting with a dentist and dental office is really important. And then ongoing frequency of visits should really be a decision made between the dental provider and you as a parent about sort of what the child's risk is like for dental problems and observation, and then maybe you may want to more frequently have that individual come into the dental office rather than just every 6 months. As I mentioned, there are these enamel defects with the outer enamel and how they form. So I thought a few pictures would be very useful here just to show you before I get into some of the results from the trial here conducted in Manitoba. So here's a picture of some primary teeth in a young toddler, where you can sort of see with this upper canine, the eye tooth here, it looks very irregular, almost like it sort of comes to a point, and that's a sort of more dentin that is visible, where the tip of the tooth, the enamel appears to be missing or malformed. The middle panel and the panel on the right of the screen are from the same adolescent male, and this individual has had HPP or has HPP, and as you can note, along sort of where the crowns and the roots form, there is the appearance of some missing enamel there, which can pose some cosmetic issues, especially if it's in the front of the mouth. So you can maybe cover those areas up with white filling materials. Because of the missing tooth structure, if hygiene isn't maintained well and diet isn't controlled, those areas are prone to tooth decay. What preventive advice do I have for parents and actually even adults with HPP? I think making sure that just like every other child, we want to encourage the use of fluoridated toothpaste, especially if you're in a community where you don't have fluoridated drinking water. So with the child who's under 3 years of age, we want to make sure that it's about a grain of rice size amount. This way, if anything's ingested, it's not harmful to the child. If the child's 3 or older, we're recommending a pea-size amount. And just like any other child, kids with HPP may not want to brush their teeth, just like children without HPP. So we are recommending parents supervising the brushing until 8 years of age. What do parents do when maybe some teeth in the anterior part or the front part of the child's mouth have maybe been lost prematurely because of HPP? I think that's a discussion that dentists and parents need to have about maybe how it's affecting the child's quality of life and maybe self-esteem. We know over the years there have been some parents who have opted for a sort of a fixed type of appliance, not a removable denture, but here where maybe bands are cemented on back teeth, and a wire with fixed prosthetic teeth are put in the front area to sort of provide sort of, you know, more aesthetics and to provide some teeth there. The challenges in doing this in very young children is you increase the risk maybe for something breaking and the child aspirating. Maybe if the teeth should fall off of such an appliance, you need to weigh that, as well as, you know, will the child be willing to undergo impressions and cementation of this type of appliance? I often get asked about HPP and orthodontics. I know of an individual with HPP who is finishing off orthodontic care, someone that I care for their dental needs or had. And when I looked in the literature, I actually did not see any literature that I could find on HPP and orthodontics or braces, as well with HPP and crowding of the teeth, I could not find. The only article I could come across was a 26-year-old article of a child who had HPP. The upper jaw and the lower jaws in the back were not lining up properly. And so the dentist in this instance made a denture in the back areas of the child's mouth. And with a little key, they were able to sort of start expanding the upper jaw outwards to rectify that discrepancy between the top and bottom jaws. But that was all that I could find. As well, HPP and permanent teeth. I know I get asked questions by some adults about what about implants. So here was an article that I came across. It's about 12 years old now. They reviewed the literature and showed a few cases where they used implants to restore the individual's mouth and replace the missing teeth. One of the patients had mild HPP and was treated with implants. 3 lower incisors had fallen out by the time this adolescent was 12 years of age. And by 20 years of age, they had lost a total of 10 permanent incisors, premolars, and first molars. They had implants placed in the lower arch and to support a partial denture to replace the missing teeth. And at age 23, there was problems with an upper tooth, so upper front tooth, so they had an implant placed. However, that implant failed. And then subsequently, a few other upper front teeth were removed, and then 3 implants were replaced, and the failed implant was removed. So they concluded sort of the success of implants in individuals with HPP is really sort of linked to the quality of the bone, recognizing that implants grow, or the bone grows through implants, so that it becomes part of the bone, so that things sort of lock into place. And so the suggestion from these specialists was adults with mild forms of HPP with no skeletal manifestations may be suitable candidates for implants. I do have a slide here. So this is one of the adults that was participating in Dr. Greenberg's trial here in her 60s. And she had long-standing dental problems that she had indicated to us over the years. She received aspartase alpha. Over the years, she has had implants. Although the upper implants were beginning to fail, and there is one more implant, an old implant left on top, but it's quite intriguing. So I had never seen these before. So she shared this photo or this image with us where she's now had 4 what we call zygomatic arch implants. So these implants are actually placed higher within almost the cheekbone areas as a way to regain some dental function as she gets her dentition rehabilitated. So now I'm just going to go on and talk for the last bit of my presentation, just the outcomes of infants and preschool age children who were participating in the clinical trial of aspartase alpha or Strensiq for early onset hypophosphatasia here in Winnipeg at the Children's Hospital Research Institute of Manitoba. And want to acknowledge Catherine Long, who was a dental student that Dr. Greenberg and I supervised. So past studies have shown that infants and children with HPP, if they're administered aspartase alpha, show significant improvements in the appearance of their bone, their physical function, and their lung function. Mice models have also shown that this treatment leads to improved mineralization of enamel. And as well, one recent study that was just published last year, which I'll speak to in a few moments, actually said that there was more stability of the teeth, so that remaining teeth did not become mobile or loose. So our purpose was just to document the patterns of loss and eruption of preschool and infant age children who were receiving aspartase alpha. The study was approved by the Biomedical Ethics Board here at the University of Manitoba, and we followed the children up as part of the overall study protocol, looking at the number of teeth that were lost at each visit and the number of teeth that were erupted. What was quite unique, because of a rare disease where you only have limited numbers of children, we actually contrasted the data between the infants who received Strensiq at a very, very early age in infancy compared to older preschool age children who had already lost some teeth, and how that compared with them receiving the treatment. Overall, there were 11 children recruited. 5 children were of infant age, so on average they were about 3 months of age when they actually commenced treatment within the study. The 6 others were preschoolers. The average age when they enrolled at the baseline was just over the 4-year mark. So they were about 4.5 years of age. What we found at enrollment, all the participants or participants in the preschool group had lost on average 10 teeth. While it's understandable, in the infants, no one had lost teeth because most were starting before they even had the first tooth even grow into the mouth. During the trial, though, it was interesting to see how many teeth were lost prematurely because of HPP between the 2 groups. So in the infant group, on average, about 2 teeth were lost during the study period. And amongst the preschool group who started treatment during sort of the preschool years, when we followed them up over the prior period, they lost almost 3 teeth. But I think what's important is as well, looking at specific instances for the children. So let's look at some of the information here. So amongst the infants, as I've mentioned before, on average, they lost about 2 teeth during the trial, but quite interesting. Unfortunately, 1 child died, so we don't have a long-standing information on that child. But of the 4 that remained, 2 actually did not lose any teeth prematurely during the study period. So the average was actually borne by the 2 children these 2 children, one lost 4 teeth, the other lost 3 teeth. And the type of teeth lost in the infant group naturally were incisors and molars because after the incisors grow into the mouth, the molars are actually the next teeth to grow. As well, now let's look at the preschool age children, where we found on average that they lost about 2.7 teeth during the study period. They lost incisors, canines, and molars. But what we did is the infant group, we followed them over time to see how many children lost teeth while they were receiving Strensiq. What we did is we looked at and compared that to the preschool or to the older preschool children who started about 4 years of age, and we compared the infant number of teeth lost with the number of teeth lost in the preschoolers before they actually started the drug, just to sort of see, here was a group that didn't get drug treatment in their early age, and here was a group that did receive drug treatment at an early age, and we actually found significant difference there. Here is just an example of sort of what we followed up for each child in the infant group and in the preschool group. But I do want to highlight here the key finding is children recruited at infants prematurely lost fewer teeth to HPP during the trial period than those who were recruited as preschoolers and had lost 10 teeth before they even started the drug trial. So I think, quite remarkably, it looks like there's maybe a huge benefit that Strensiq may have on preserving primary teeth in young children if they're getting administered very early. So I think this is the crucial piece is for those with early onset HPP, the sooner that drug is administered right after birth, the better implications we have for the dentition. I will skip over this slide for the sake of time, but I do want to highlight this Russian article which was just published. So again, here they were telling us about 16 children who were that they were following with HPP, and 10 of them were actually receiving aspartase alpha. This group is much older than the group that we were following, than our 11 children here that were followed at our site. And as we can see here, there were 3 different forms of HPP amongst the 16. They only, unfortunately, it's good that they reported this, but unfortunately they only presented dental data on 3 of the children. So case 2 was a 4-year-old girl who was receiving the enzyme replacement for over 3 years. And they basically concluded that there was a complete lack of mobility of remaining primary teeth. So they didn't follow the same outcomes that we were following here in our study. But again, interesting that they were saying that there was a benefit on the dentition. Case 3 was a 10-year-old female who received enzyme replacement therapy. Unfortunately, they said that they didn't collect anything on mobility or periodontal health. And I think because she was receiving treatment at much later age, there was no real benefit on teeth that had formed before, because once teeth form, we can't alter that. But in future years, I would imagine that more of her adult teeth would benefit from her ongoing treatment. And the last case was a 2.5-year-old male who received enzyme replacement therapy, did lose primary lower incisors, but they commented that the mobility of the upper primary central incisors actually decreased significantly. So they were concluding that aspartame alpha, that none of the children that they were following who received this drug developed premature mobility of previously stable teeth. So again, encouraging news with Strensiq. I do want to mention, here's an interesting x-ray of an adolescent who was receiving Strensiq. The adult teeth, the most of them there have been severely affected by HPP, but what's encouraging is to see these second permanent molars in the back that are starting to form, where we can actually see white enamel there. So it's telling us that they're mineralizing more. They're more radio-opaque, which is a great encouraging sign. So that even in the adult dentition, if teeth are still forming and not erupted, that Strensiq may have improvement there with mineralization of teeth. So there were some limitations with our study. We didn't always have dental data at each visit, as some children might have missed visits, or we might have not been able to get dental assessments done. We didn't have x-rays to follow them, and it's understandable, especially for the young infants, that's very difficult to achieve. And one child, unfortunately, passed before the 9-month of age visit due to complications with HPP. So we're encouraged. We think participants in the infant group receiving Strensiq had significantly fewer teeth that were lost early compared to children who commenced aspartame alpha as a preschooler. And I think even though it's a small number of patients, it really does show that enzyme replacement therapy has improvements on the dentition of children. So the implications, I think, for future research, we do need more dental assessment for these children and youth as they age. I think it's very important to maybe see if we can capture some of their clinical data. And I think just overall in general, more research and clinical dental outcomes in patients, both children and adults with HPP is recommended, considering I found no or very little literature out there on certain issues, including orthodontics. So I do want to acknowledge funding for the study for Dr. Greenberg's research team members who helped with and coordinated all of those visits, and as well to the Children's Hospital Research Institute of Manitoba for their support.
I want to thank both of you on behalf of Soft Bones Canada for being with us. I want to thank everybody for coming. If people weren't able to come or came late to the party and would like to see this, it should be on our website, www.softbonescanada.ca. Hopefully that will be up soon, within the next week or so. We continue to work to educate, empower, and connect patients, families, and caregivers. We look forward to offering more webinars like this event. So if you have suggestions, questions, don't hesitate to reach out to us. We always want to know what you're looking for and how we can help. It's a great way for us to connect. Not only are we a rare disease, but we're all across the nation. So we have a pretty big country. So it's very difficult for us to get together physically. So this is a wonderful way for us to be able to get together in real time. So please continue to use our website as a resource. Send us emails if you have questions or concerns. And if you've not already done so, please consider registering with Soft Bones Canada so that you get updates about events like this. So thanks again to Dr. Schroth and Dr. McKee for joining us. And thanks especially to Eric, who's been behind the scenes running the show. And we look forward to presenting more things like this in the future.